with the simulation session for group A. Rest all of you will able to see downstairs what they are performing, and at the end we'll debrief, and that time if you have any questions you can ask us. We'll have 8 simulation sessions today, and around 5:30 or so we'll start taking your the practical exams of power failure, individual power failure. That will be started simultaneously downstairs. Okay. After finishing with these 8 sessions, we have one more interesting session around 6 o'clock. So don't go away once you finish with the session. Please stay till end, and at 6 o'clock there will be one more interesting session will be there. So that will let you know once we finish with this. Okay. So fine. Welcome to all of you. All of you will please keep your mic on, and you have to speak on your mic so that everybody downstairs can listen to what you are talking. Okay. So this is, I think I have told you, this is our simulation lab, and what we are going to do is this hemodynamic monitor you can see upstairs. We'll able to see slides and hemodynamic monitoring here. ECMO monitor we will able to see on the ECMO parameters. Okay, and ventilator parameters over here. Okay, and this is going to be your patient. Okay, so this is a case 1. Is 10 years boy, 20 kg, known case of multiple sclerosis on immunosuppressant, developed viral pneumonia, ARDS, he was on ventilator since 2 days, PF was 68, failed proning, RT-PCR was done which was negative. Okay, and this child is then,
What is that, MS?
this child is then considered for an ECMO, and he was put on ECMO. Immediately after putting on ECMO, this is the X-ray what you can see. You can see the return cannula and drainage cannula. Okay. And the parameters what you can see is, yeah, you can see the parameters now. His heart rate is 98, SHS is 92, mean heart rate is 74, okay, and it is CO2 22. Now it's over to you. This is your patient. If you want any more information, you can ask me. Today is day 3 of patient on ECMO. Okay. So this is your patient. You have to manage. If you want any more information, you have to ask me whatever information you want, and you have to monitor the patient as if you are monitoring the ICU patient.
What were the baseline pressures, sir, when the patient was put on ECMO?
Yeah, circuit pressures are almost the same, whatever you are
Almost.
seeing. Yeah, there's no change in the circuit pressures. Okay.
Sir.
If you want to ask me anything, you can ask me.
Ventilator settings.
21%
FiO2 is
on
only
ventilator.
21%.
Taken on
It's a
ECMO.
ECMO.
The sweep gas and blender.
Blender.
How much is the gas flow?
FiO2. FiO2 100. Sweep gas. Sweep gas 3, I think.
3 liters.
3 liters.
Any lactates level, sir?
So the patient is
Excuse me, sir.
desaturating on the monitor.
Monitor.
So what-
A patient is
Speak little loudly so that everybody can listen now.
a patient is
Patient-
desaturating. Yeah.
So you
tachycardia.
act.
yes.
Don't tell me.
Okay. We'll take on the emergency vent.
Tube colors
Sir,
are same,
Well,
sir.
I
Tube
would like
colors
to
have changed, and
Yeah.
the P1 pressure is also becoming
Tube color I don't see
No,
same. Both
tube-
are different.
Difference.
Yeah.
Both tube colors both are different. First, I would like to address the problem immediately before and start thinking about the problem of why the patient is desaturating. So I would like to increase the flow of ECMO.
How much is the flow?
So flow has
Flow is-
come
Flow
down
has
actually,
come down.
0.5
0.5,
liters.
sir.
Flow has come down.
So do whatever you want.
I'll increase the RPM.
No,
What's the pressures? Delta pressure?
Delta pressure also is changed.
Yeah.
P1 is reduced.
So could be some problem with the
P1 has become more negative, so probably
will
the
give some
patient is
hypovolemic.
hypovolemic. I would like to give
Give
fluids
some
to the
fluids,
patient.
to the
Please
patient.
give a full fluid bolus
How
of
much you want to give me fluid?
500 ml
500
of
ml bolus.
crystalloid.
Okay, 500 ml of fluid
I will
was
check
given.
the cannula site if any bleeding is there.
No kinking.
See if anything has, we would like to see if the cannulas have moved.
No.
Nothing.
No
kinking.
kinking,
That.
no blockages.
So what was the hemoglobin you are transferring when you were PRBC?
PRBC.
Hemoglobin is around 10.
10. Okay. What was the lactate level, sir? Initial lactate level?
Lactate level was 1.8.
Have we given the fluid
Fluid,
bolus, sir?
sir?
Fluid given.
Increase the ventilator
Yeah.
settings. FI to tidal volume.
200%.
What's the patient weight, sir?
20 kilos.
20.
The pump is still, the flows are still low.
The P1 is also more negative right now.
Even though the flows are low?
We would like to reduce the RPM since the pressure is getting more negative.
See,
Probably it is cavitation is happening, so I would like to reduce the flow RPM.
You do whatever you want.
Reduce the
Saturate,
RPM.
reduce the
Reduce the RPM.
Check for any air or anything. The hypoperfusion, I think.
Yes.
I don't see saturations.
What's the temperature?
Temperature is 37.
Patient is going,
But
is landing up in bradycardia.
So
Yeah.
I want to give one more fluid bolus. Fluid bolus is
How much you want to give fluid bolus?
500 ml.
500 ml in this pediatric child.
Get ready for
CPR.
CPR. Patient is
Okay,
landing
give
up in bradycardia and arrest, probable arrest. So get ready for CPR.
Do whatever you want. This is your patient.
okay, P1
Keep all the
is
emergency
settling.
drugs ready. Bicarbonate,
P1 pressure is getting.
atropine,
is
Yeah.
adrenaline.
But the
There
flows are
must be
still,
kinking.
Yes.
What was the problem? How much is flow now?
now it's increased to
Increased
1.8, so there was
1.8, sir.
kinking in the line.
There was a kinking in the line.
Yes.
Okay. How did you identify there was a kinking in the line?
The flows were not increasing despite everything. I
Despite
saw
fluid
the
bolus,
Using
everything.
Getting a
railing which
bolus.
was compressing the tube.
Okay.
Delta pressures are better now.
The saturation is
Saturation.
picking up.
All the pressures have almost come to the
Yeah, normal.
previous values.
Heart rate and saturation is picking up.
Okay.
Heart rate settled, saturation
come down
improving.
BP also picking
BP
up.
is still picking up.
It can reduce the effect.
So everything is fine now?
We can get to rest ventilator settings.
Getting better, sir.
Yeah.
Yes.
Okay. Fine. Okay, so that ends your scenario. What was your scenario was?
Kinking of the
Kinking
line.
Kinking of the
Right.
cannula.
How will you diagnose that?
Because of
the
sudden-
With
flows
the pressures
decrease.
and also the flows.
Initially there was an
immediately
increase.
there was a fall in the flow, sir.
1%.
despite corrective measures, the flows were still not improving by either reducing or increasing the pump speed. Then we noticed that usually there should be a mechanical obstruction. So we started with fluid resuscitation. After fluid resuscitation, even then the flow did not increase. So then we looked at the mechanical problems like kinking.
Kinking.
So when we noticed that there was a definite kinking in the
Sidebars,
bedside. So
railings.
the railings had actually kinked the
Tube.
drainage cannula. So the drainage cannula was the issue.
Okay.
And it was very sudden, so not a gradual one. And the flow change was sudden.
Initially there was hypotension, hypoxia.
So why did you think about drainage cannula only? Why not return cannula?
Because
The
the
Color
P1 are
change
more
was
negative.
okay.
The pressures were initially
P1
more
was more
negative.
negative.
P1 was
P1
more
pressure
negative.
was more
negative.
negative.
Okay, so you thought more
So-
something wrong
so
with
first
the...
drainage
Okay.
cannula.
Suppose there was no kink at that point. Okay. What other thing could have been?
There might
Volume
be
status
bleeding,
we would
internal
have
bleeding.
to check, which we already gave
Then
fluid bolus to the
boluses.
patient.
Then
Then
we also
There might
we
be
also
some
check
internal
for
bleeding.
cannula movement. Has the cannula been displaced or
Displaced.
something?
Displays are dislocated. We only checked the cannula side bleeding.
Or probably if we would have checked if the demand is increased, like the patient is
agitated
agitated
or,
or awake.
awake. And then when we asked about the blood, so the
What was the
hemoglobin is
hemoglobin
already more than
grams?
We thought of internal bleeding, but you already said the hemoglobin,
Hemoglobin
is
is
10.
10.
So that patient related was good.
Was there a chattering you saw?
initially.
No, sir.
No,
actually
there was
we
no
didn't-
chattering.
we didn't
No
see
chattering.
Okay, fine. Anything else you have noticed?
And the tube,
Tube.
colors,
La-
we noticed that was okay.
There was no.
There was a
The colors were
Initially we
acceptable.
started with the tube colors which were acceptable. The two colors were different.
Okay, fine. Now, before I come to what you have done, can you retrospect yourself and tell us what went wrong or bit late, and how you can
Mechanical-
perform the better next time in the better way?
Mechanical causes should have been
We
on
ruled out
a
initially.
little top list, while we have already identified there is problem with the drainage side, and problem is hypotension. The pressures are getting negative. So mechanical complication would have been the first, second DDs when we started thinking.
Okay. Anything else?
A systematic approach was missing. It should have been
Yes.
started from the machine end or the
Machine.
patient end. So ideally, patient end to the machine would have been the best approach because the cannula site is where we start with. So
Okay. A bit before that, you are now going in a right track. I agree.
we didn't
A bit before
role
that.
allocation was not given.
roll out.
Yes. You have not divided yourself in a team. So when you come here, you should have divided yourself in team. Yes, this 3 person is going to manage the patient. This 3 person is going to manage the circuit and everything. Okay, fine. When you have been given a time to monitor this patient, did you examine the patient?
No.
You just standing, isn't
Yes.
it?
Yes, sir.
You could have came, examined the patient. You could have asked
Yes.
many things.
We could have asked about the CBCs and coagulation
Yes,
patterns.
ACT, CVC.
Yes.
Yes, sir.
Would have, but there are a lot of
Yes.
things, information you need to take, isn't it? When you are taking an over. I understand this is your first simulation scenario, so you are the first batch. So these things happens, but then I just want that this should go
Systematic.
and systematic. Okay. Next time, this too. It's good that you diagnose it. I'll say a bit late. Okay.
But actually, we have noticed it, sir. But
You
we didn't-
noticed, but
there was
notice-
no kinking. There. We have
We actually
noticed that
saw the cannula, but there was
in
no
We didn't
stuck in
expect
the
that
railings,
absolute
but there-
kinking. So
It was.
no,
key.
it was there, but
it was stuck in between the railings, but there was no kinking.
Yeah,
actually.
it was stuck between, and this is what happens commonly. Okay. So anyway, what I want to say is that you diagnose it. Okay. So first thing what you notice is what are the
tube
first-
colors,
No,
pressures,
Pressures,
Pressures.
flows.
you flows. With the same RPM, the flow is
Flow
decreased.
decreased.
Okay, that is the first thing you notice.
Yes, yes.
Second,
pressures.
P1 pressure become more negative. You said
negative.
clearly, isn't it?
Yes.
Yes.
Okay. So now that it was very clear that there is something
Drainage.
wrong in the venous line. So that
Yes.
was very clear. Okay.
Yes.
Then
Then we
Next,
searched.
We ruled out the
searched-
bleeding at the cannula set.
yes, bleeding at the
Bleeding.
cannula sites.
We
Okay.
need-
Now, if you go a bit ahead, okay. Was chattering?
No, sir.
No, sir.
Usually, if there's an hypovolemia,
Chat.
There is.
okay,
There will be chat.
you will get to see chattering because there's a lot of suction that the machine is going to do it. Okay, so there will be a chattering. Now, why didn't you see your chattering here? There was something wrong with the venous part. Why didn't you see the chattering here?
Because of the occlusion.
Yes, occlusion.
Okay.
So your negative pressure of the pump
Generally, the
was not
chattering
getting transmitted to the vessel wall.
Vessel wall. Yes. Generally, the chattering is because the
Yes.
vessel wall gets abutted to
Abut-
our cannula tip, which
Yes.
and then released. So intermittent suction and release of vessel wall leads to chattering, but it was not in our
Yes.
case.
And
That's why.
So again, that rules out your hypovolemia side.
Yes.
Okay. Third thing, was it sudden or gradual?
Sudden.
Sudden.
It was absolute sudden.
Sudden.
So if it is an absolute sudden, then it is more likely to be
Mechanical.
kink
Mechanical.
outside the circuit. It can be a clot in the venous cannula also, but in that scenario, probably you could have got some chattering to be seen. Okay. So that is the way how will you differentiate? That is the way your mind should go. Okay. Third thing is, whenever you see anything, okay, any complications, I told you, first thing you have to see about mechanical. What you have done is, you have done right, you look at the cannula, but you didn't bother to trace
Trace
the
the
circuit. You could have gone either a venous to artery line, or return line, or return to drainage line. See, either of this direction. If you have gone to that direction, probably you would have picked up it easily and things would have sorted out. Okay. I have to get him to bradycardia for you to realize this.
Yes.
Okay.
Yes.
If you have seen the response, initial response was hypoxia,
Yes.
hypertension,
Hypertension.
tachycardia. Okay, that's an immediate response. And then what happens? The CO2 starts building up. And when the CO2 starts building up, it gives rise to
Bradycardia.
it gives rise to bradycardia, and then
Eventually
patient goes
arrest.
into hypotension and that. If you are still not diagnosed, probably patient could have been arrested. Okay. So those patients who are ECMO dependent, okay, you have to be mindful about that. Okay. One more thing you should have done is, the moment you say that ECMO flow has gone down, okay, with P1 has become more negative, you try to go up the ECMO. See, when I showed you in lecture very clearly, if there's something wrong with an ECMO, go up on the ventilator.
We already
The
did
first thing, you did it. I don't say you didn't, but you did it second. The first thing you should have gone is up on the ventilator settings immediately rather than going on a ECMO setting, because it's likely that there's something wrong with the ECMO. So you should have gone up on the ventilator. You increase the RPM, that can cause cavitation.
Cavitation.
Luckily, because the tube was kinked, that reflex didn't go up to the vessels,
Later we
and then
realized
cavitation
that-
didn't occur. And then you realized that, and then you came down on the RPM. Okay. So that was the right thing what you have done at that time. Okay. So these are the few things that you need to understand, that circuit related complications, sudden and drastic, and that they are easy to solve, and it can be life threatening. Then you have seen that how rapidly the patient has gone into a bradycardia, hypotension, immediately first was a tachy and then immediate bradycardia and hypotension. That is what typically that things get happen. Okay. What are the other possibilities which can present you similarly? One you said is vessel wall getting, cannula getting abetting somewhere,
We didn't
hypovolemia.
We didn't see for any coagulation disturbances. We'll see the ACT, and if the coagulation are a bit disturbed, we will
Any
also
clot
search for any
formation.
cause for bleeding, if there is any bleeding or something, and clot in the venous circulation.
Yes. So you have to, another thing that is clot not in the venous, it can be anywhere in the venous line, or most probably can be clot in the venous cannula. The clot in the venous cannula will also mimic like something like this, but usually it gives some chattering. Unless the clot is suddenly sitting on the cannula completely, and it is sudden obstruction of the cannula completely, you may not see the chattering, because again the negative pressure is not getting transmitted. But otherwise, most of the time you get some chattering when there is a cannula is getting blocked, and that is probably something which is dreaded complications. Okay, and the management of that is going to be something totally different. Okay, so always first whenever you see sudden change, look at the circuit, and invariably you get the answers in the circuit. That is the commonest thing that can happen. Okay. Anything on more?
Increased demand, that we can check if we.
Okay. Anything else you want to ask me?
How do we diagnose the venous clot, sir, in the circuit, the cannula inside the body?
So again, there will P1 become more negative. With the same RPM, the flow is gone down.
Chattering.
Okay. So it means there is some, and there is no kink. So it means there is a clot somewhere, either in the pump or in the cannula. What you do is, most probably it is going to be, because the P1 has become more negative, most probably it is going to be in the cannula. Okay, when you cannot see outside. Okay. But how will you confirm? You connect it to bridge, open the bridge.
Circulate.
So if the circulation is going in well in the bridge, that
That
means circuit is okay, something wrong with the
Cannula.
cannula. That is the way you will able to diagnose. Okay. Fine. So anyway, you picked up it at the last minute so that patient didn't go arrest, and and the response also immediate. Within 20 seconds, saturation has come up and heart rate has come up. All circuit pressures, everything got normalized. So that's because that's just a kink. You relieve the kink, the response was immediate. Okay. So always remember that with sudden things, you have to think mostly there can be something like a issues with the circuit. Okay. Another thing that can give rise to something like this is your tamponade effect.
But it was 2 days later.
Yeah, so that is less likely. But what are the other differential diagnoses I am talking about? It's can be a tamponade effect. But again, tamponade effect probably is not going to be that sudden. It's going to be gradual. Gradually, your flow will come down. because the cannula will get obstructed because of the tamponade effect. So that's again going to be a more of a gradual rather than a sudden response that is going to come. Okay, and probably in that also we are going to get to see a chattering. Okay, fine. So well done. Anything you want to say, Kapil or Vishal?
From audience?
Or any question from audience? Could you see the kinking?
Yes, sir.
Okay, fine.
Any from the audience?
So, sir, there was leak also, and means inspiratory tidal volume was around 180 and expiratory was around 40, and in volume that was not it was going below the baseline level and not going up to 40-50 ml. So, in the case of pneumothorax, if there is if there is something which is causing the air to get there, we will get a leak and hypotension with increased pressure. So P1 will also be low. P1 will also be more negative.
Yes, but usually this is not going to come. As I told, that will come only when there is a tamponade effect. That's the last point I discussed. Because the tamponade you can get similar picture. Either tamponade because of cardiac tamponade, because of the tamponade because of the tension pneumothorax. Okay. So that can also present like this, but that is usually going to be a gradual. You know, your flow will slowly come down, and you will get chattering, and then the things will happen. May not be so rapidly. Okay. So that is the one factor, and obviously it still can happen when the patient on rest ventilator settings, but the chances are going to be little as compared to little less. And the patient usually first develops hypotension, tachycardia, and then the flow will decrease. Okay. So that is going to be the sequence. The sequence also here is different. First the flow decrease, then tachycardia, desaturation, and hypertensive response. So that was a difference. How will you differentiate best two? But it's a good point you raised. Any other questions? Okay. So you can send team B.
Sir, there is one question. Team B is upstairs.
It's upstairs only. Okay, no problems.
Sir, what is the importance of core to peripheral temperature difference in this patient? It was 32 for peripheral and 37, more than 37 for core.
No, that's periphery temperature can be, what is important is going to be core temperature. So that is what you have to just keep in mind.
Okay. So it doesn't matter?
Doesn't matter.
Okay.
Fine.
Okay, sir.
So well done. Before you leave, one lesson you learned from this scenario. Yes. From this scenario. Yes. We'll start from you. What you learned from this scenario? What you have learned from this scenario?
I think he has some language issues. He cannot fluently understand English.
Okay.
No understand.
Fine.
You have to be strong with the basics when you're understanding about your patient. So first, analyze your patient before you jump to any conclusions. Examine the patient first.
Yeah, the examining patient is very important. The way you follow head to foot, or you have to follow like drainage to return or return to drainage. Okay. Yes.
Yes. Look at the flows, whether increasing, decreasing the flows, the P1 pressures, to identify if there is any problem over here.
Okay. So look at the RPM flow ratio and the circuit pressures. Fine.
A systematic approach should have been there, so probably
I want something different. He has already said that.
Another thing, whenever the differentiating, first differentiate whether the problem is with ECMO or with the ventilator and separate the two entities.
Yes, so first find out whether problem is with ECMO or ventilator. If problem is with ECMO, go up on the ventilator. Okay, fine.
Role allocation. Role allocation.
Role allocation, yeah. You should divide yourself, whenever you get some troubleshoots, you should divide yourself in two teams and allocate the role to everyone.
Yeah, commonest DD should be ruled out initially, so
Like
kinking and all this mechanical things to be ruled out first,
yeah.
and then
Always first look for the mechanical cause, especially if there is a sudden, look for the mechanical cause, because that is going to be life-threatening. Okay, something going wrong with the patient may not be life-threatening, but this is going to be life-threatening because patient is ECMO dependent. Okay, thank you.
thank you, sir.
Thank you, sir.